Welcome back, everyone. Let's start from the remains of yesterday's lecture, the management of hypertrophic cardiomyopathy. Let's first discuss how hypertrophic cardiomyopathy is managed. The initial step is to avoid factors that worsen left ventricular outflow tract obstruction. Conditions such as volume depletion or dehydration can increase the obstruction and should be avoided. Patients should also avoid high-intensity competitive sports, although mild to moderate intensity exercise is generally considered safe. Medical therapy. The cornerstone of the treatment is medical management. Beta blockers are the first line therapy because they reduce heart rate, prolong diastolic filling time, and decrease the left ventricular outflow tract gradient. If beta blockers are ineffective or contraindicated, verapamil or diltiazem, which are non-dihydropyridine calcium channel blockers, may be used. These medications should be started only in monitored setting because of the risk of hemodynamic instability. Other medications include disopyramide, which provides a negative inotropic effect and further reduces obstruction. Phenylephrine, particularly in patients with cardiogenic shock because it increases afterload without increasing contractility. Mavacamten, a selective cardiac myosin inhibitor that directly reduces myocardial contractility and improves symptoms in obstructive hypertrophic cardiomyopathy. At the same time, certain medications should be avoided because they worsen obstruction by reducing preload or afterload. These include digoxin, vasodilators such as nitrates, dihydropyridine calcium channel blockers, ACE inhibitors, and ARBs. These drugs may increase the outflow tract gradient and worsen symptoms. Septal reduction therapy. Patients with Dirac refractory symptomatic obstructive hypertrophic cardiomyopathy should be referred to experienced centers for septal reduction therapy. Available options include surgical septal myectomy, which remains the gold standard for eligible patients. Alcohol septal ablation, percutaneous procedure that injects ethanol into a septal artery to intentionally infarct and reduce the hypertrophied septum. Dual chamber pacing, which is now rarely performed because of limited benefit. Management of non-obstructive hypertrophic cardiomyopathy. For non-obstructive hypertrophic cardiomyopathy, symptomatic patients are treated primarily with beta blockers, 9-dihydropyridine calcium channel blockers, diuretics if symptoms remain despite initial therapy. Associated conditions. Patients who develop atrial fibrillation require anticoagulation with either a direct oral anticoagulant or warfarin, regardless of their CHA2DS2 VAS score, because hypertrophic cardiomyopathy itself carries a high thromboembolic risk. Patients who progress to systolic dysfunction should receive a standard heart failure therapy, including consideration of heart transplantation in advanced diseases. Implantable cardioverter defibrillators. Patients at high risk of sudden cardiac death should receive an implantable cardioverter defibrillator or ICD. The major indications include previous cardiac arrest or sustained ventricular tachycardia, family history of premature sudden cardiac death, unexplained syncope suspected to be arrhythmic, left ventricular ejection fraction below 50%, left ventricular apical aneurysm, non-sustained ventricular tachycardia, and ambulatory monitoring. marked left ventricular hypertrophy with a maximum wall thickness of 30 millimeters or greater. Mavacamten clinical trial. The boxed summary on the right highlights the Explorer hypertrophic cardiomyopathy trial, which demonstrated that mavacamten significantly improved exercise capacity, reduced left ventricular outflow tract obstruction, improved NYHA functional class, and enhanced overall health status in patients with symptomatic obstructive hypertrophic cardiomyopathy. Prognosis of hypertrophic cardiomyopathy. Moving on to the prognosis, life expectancy may or may not be reduced. And mortality, most patients never develop severe symptoms or require aggressive intervention. However, potential complications include atrial fibrillation, stroke, congestive heart failure, both diastolic and systolic, ventricular tachycardia, and sudden cardiac death. Although the annual risk of sudden cardiac death is approximately 1% per year, hypertrophic cardiomyopathy remains the most common cause of sudden cardiac death in young athletes. Restrictive cardiomyopathy. Now let's discuss restrictive cardiomyopathy, often abbreviated as RCM. Definition. Restrictive cardiomyopathy is characterized by impaired ventricular filling with preserved systolic function in a non-dilated, non-hypertrophied ventricle. The primary problem is reduced myocardial compliance, usually due to fibrosis or infiltration. Because ventricular filling is impaired, patients commonly develop biatrial enlargement, even though the atrioventricular valves remain structurally normal. Etiology. The most common causes are amyloidosis, sarcoidosis, hemochromatosis, and these can be grouped into several categories. Infiltrative diseases. These include amyloidosis, sarcoidosis. Non-infiltrative causes. Example include scleroderma, idiopathic myocardial fibrosis, diabetic cardiomyopathy. Storage diseases. These include hemochromatosis, Fabry disease, Gaucher disease, glycogen storage disorder, endomyocardial disorders. The endomyocardial disorders include endomyocardial fibrosis, Loeffler endocarditis, eosinophilic endomyocardial disease, and other causes include radiation-induced heart disease, carcinoid syndrome, which may also produce tricuspid or pulmonary valve dysfunction. Clinical manifestations. Patients usually present with heart failure despite preserved left ventricular systolic function. Other common features include cardiac arrhythmias, elevated jugular venous pressure with prominent X and Y descendant, Kussmaul signs where the jugular venous pressure rises during inspiration, third and fourth heart sounds, mitral and tricuspid regurgitation, and thromboembolic events due to atrial enlargement. Investigations. Several investigations help establish the diagnosis. Electrocardiography may show low voltage QRS complexes, non-specific T-wave abnormalities, occasionally non-ischemic Q waves. Chest X-ray often demonstrates mild cardiomegaly due to biatrial enlargement. Echocardiography typically shows left and right atrial enlargement characteristics, Doppler findings of restrictive filling, minimal respiratory variation, helping differentiate RCM from constrictive pericarditis. Cardiac MRI is particularly valuable because it detects myocardial fibrosis, identifies infiltrative diseases, helps distinguish restrictive cardiomyopathy from constrictive pericarditis. Cardiac catheterization demonstrates elevated ventricular and diastolic pressure. Finally, endomyocardial biopsy may be required to determine the underlying cause, particularly when infiltrative diseases such as amyloidosis are suspected. RCM versus constrictive pericarditis. The comparison table on the right summarizes the important differences between restrictive cardiomyopathy and constrictive pericarditis. Although both conditions produce similar symptoms of diastolic heart failure, constrictive pericarditis is potentially curable with surgery, making accurate differentiation is extremely important. Helpful distinguishing features include restrictive cardiomyopathy often has a family history, elevated BNP levels, myocardial fibrosis on cardiac MRI, and a normal precardium. Constrictive pericarditis is more likely to have a history of prior cardiac surgery, pericardial calcification or thickening, pericardial rub, reduced BNP level, and characteristics of late gadolinium enhancement of the pericardium rather than the myocardium. To summarize this page, avoid dehydration and use beta blockers as a first-line therapy for hypertrophic cardiomyopathy. Consider septal reduction therapy for symptomatic obstructive hypertrophic cardiomyopathy that is refractory to medication. ICDs are essential for patients at a high risk of sudden cardiac death. Mavacamten is an important newer therapy that improves symptoms in obstructive hypertrophic cardiomyopathy. Restrictive cardiomyopathy is primarily a disease of systolic dysfunction due to decreased ventricular compliance, most commonly caused by infiltrative diseases such as amyloidosis. Differentiating restrictive cardiomyopathy from constrictive pericarditis is critical because constrictive pericarditis is potentially reversible with surgical treatment. Restrictive cardiomyopathy management. Let's begin with the management of restrictive cardiomyopathy. The first step is to exclude constrictive pericarditis, since it presents with similar signs and symptoms but is surgically treatable condition. Next, heart rate should be controlled, and patients with atrial fibrillation should receive anticoagulation to reduce the risk of thromboembolic events. Treatment should also focus on underlying causes whenever possible. Examples include cardiac amyloidosis, cardiac sarcoidosis, and hemochromatosis, where disease-specific therapy may improve outcomes. Supportive care is equally important. This includes treatment of congestive heart failure, management of arrhythmias, and prevention of sudden cardiac death in patients who meet indications for implantable defibrillator therapy. When using diuretics, caution is necessary. Although they reduce filling pressure and relieve congestion, excessive diuresis can lower preload too much, leading to hypoperfusion because these patients rely on relatively high filling pressure to maintain cardiac output. For patients with advanced heart failure that remain refractory to optimal medical therapy, cardiac transplantation may be considered. Regarding prognosis, restrictive cardiomyopathy has a variable outlook and is largely dependent on the underlying etiology. Key investigations. Before moving on, notice the key investigations box. Echocardiography may demonstrate respiratory variation in blood flow, particularly in constrictive pericarditis. CT scanning can reveal pericardial thickening and calcification, findings that strongly support constrictive pericarditis. Cardiac MRI is considered the best imaging modality because it directly visualizes both the pericardium and the myocardium, helping distinguish restrictive cardiomyopathy from constrictive pericarditis. Left ventricular non-compaction cardiomyopathy. Now let's discuss left ventricular non-compaction cardiomyopathy, often abbreviated as LVNC. LVNC results from a failure of normal embryologic compaction of the left ventricular myocardium. As a result, numerous endomyocardial trabeculations remain, becoming usually prominent. These abnormal trabeculations are found most commonly in the left ventricular apex. Etiology. The genetics of LVNC remains incompletely understood. Most identified mutations involve genes encoding sarcomeric, cytoskeletal, and mitochondrial proteins. Increasingly, LVNC may occur in healthy individuals, including athletes and pregnant women, without causing disease. It is also associated with congenital heart disease and other cardiomyopathies such as hypertrophic cardiomyopathy, restrictive cardiomyopathy, dilated cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. Some cases may even be reversible, highlighting the heterogeneous nature of this condition. Clinical manifestation. Clinical presentation is highly variable. If LVNC occurs without associated cardiomyopathy or congenital heart disease, it may be completely benign. Symptoms range from shortness of breath on exertion to symptoms at rest, although many patients remain asymptomatic. Patients are at risk for ventricular arrhythmias and complete atrioventricular block, which may present with syncope or sudden cardiac death. Another important complication is thromboembolism, especially in patients who develop left ventricular systolic dysfunction and ventricular dilation. Investigations. Evaluations should include assessment for associated congenital heart disease or other cardiomyopathies. The principal imaging modalities are transthoracic echocardiography and cardiac MRI. The most common used diagnostic criterion is a non-compacted to compacted myocardial thickness ratio greater than 2:1 at the end diastole. Routine genetic screening remains controversial. However, it is commonly performed when LVNC coexists with another inherited cardiomyopathy. Management. Management focuses on preventing complications rather than correcting the myocardial abnormality itself. First-degree relatives should undergo screening, especially when a familial disorder is suspected. Treatment is guided by associated left ventricular dysfunction, arrhythmias, and congenital heart disease. An implantable cardioverter defibrillator or ICD should be considered in patients with syncope, documented ventricular tachycardia, or significant left ventricular systolic dysfunction. Because thromboembolism is a concern, antiplatelet therapy or systemic anticoagulation should be considered in adults, particularly when the left ventricle or atria are dilated. Prognosis. The prognosis depends mainly on left ventricular function and the presence of associated conditions, particularly congenital heart disease and other cardiomyopathies. Cardiac transplantation. Finally, let's introduce cardiac transplantation, which is the definitive treatment for selected patients with end-stage heart failure. The median survival following transplantation is approximately 12.5 years, extending to about 14.8 years among patients who survive the first postoperative year. Successful donor selection requires matching based on blood type, body size, and weight, ideally within 25% HLA compatibility, and geographic proximity to minimize ischemic time. Indications for surgery. Cardiac transplantation is considered for patients with severe cardiac disability despite maximal medical therapy. Examples include patients with recurrent hospitalization for heart failure, NYHA class 3 or 4 symptoms, or a peak oxygen consumption below 14 milliliter per kilogram per minute in the absence of beta blockers therapy, provided the expected survival without transplantation is approximately 12 to 18 months. It is also indicated in patients with symptomatic cardiac ischemia that cannot be treated by conventional revascularizations, such as severe angina not amenable to CABG or PCI, particularly when accompanied by a left ventricular ejection fraction below 20 to 25% or recurrent symptomatic ventricular arrhythmias. Patients with high risk heart failure syndromes or HFSS are strong candidates for cardiac transplantation. The heart failure survival score or HFSS is a validated risk prediction model that estimates survival in patients with advanced heart failure. It incorporates several clinical variables, including the patient's heart rate, serum sodium level, presence of ischemic cardiomyopathy, left ventricular ejection fraction, peak myocardial oxygen consumption, mean arterial pressure, and intraventricular conduction delay. Patients with a medium risk HFSS ranging from 7.2 to 8.1 have an approximately 73% one-year survival, while those with a high risk HFSS below 7.2 have only about 43% or 1-43% survival. These patients derive significant survival benefits from cardiac transplantation. Another indication is cardiogenic shock requiring continuous intravenous inotropic support or mechanical circulatory support to maintain adequate organ perfusion. In addition, transplantation should be considered when all other surgical treatment options have been exhausted or rare, no longer feasible. Absolute contraindications. Let's now discuss the absolute contraindications to cardiac transplantation. These are conditions in which transplantations should not be performed because the risks outweigh the benefits. These include active alcohol or substance use disorder, active smoking, significant coagulopathy, incurable malignancy, irreversible dysfunction of another major organ such as advanced liver or kidney disease, irreversible pulmonary hypertension characterized by pulmonary vascular resistance greater than 5 Wood unit, transpulmonary gradient over 18 millimeters of mercury, or systolic pulmonary artery pressure above 60 millimeters of mercury, because the donor heart is unable to tolerate severe pulmonary vascular resistance. Major systemic illness limiting life expectancy, severe psychiatric illness or cognitive impairment that prevents adherence to lifelong treatment, repeated non-adherence to medications, severe chronic obstructive pulmonary disease, particularly with an FEV less than 1 liter, and severe symptomatic cerebrovascular disease. Relative contraindications. Next are relative contraindications, where transplantation may still be considered after careful evaluation. These include active systemic infection, acute peptic ulcer disease, age greater than 70 years, diabetes mellitus with end organ damage, lack of adequate family or social support, severe obesity with a BMI greater than 35 kilograms, and significant symptomatic carotid artery disease or peripheral vascular disease. These factors increase operative risk but do not absolutely exclude transplantation. Prerequisites. Before listing a patient for transplantation, certain prerequisites must be fulfilled. The patient should demonstrate psychosocial stability, ensuring they can cope with the emotional and practical demands after transplantation. They must also be motivated, medically compliant, and willing to adhere to lifelong follow-up, immunosuppressive therapy, and lifestyle modifications. Complications of cardiac transplantation. Now let's us review the major complications after heart transplantation. Rejection. The first and perhaps most important complication is rejection. Fortunately, with the modern immunosuppressive therapy, the incidence of rejections has declined to less than 13%. Any suspected episode requires prompt treatment, especially if associated with hemodynamic compromises. The gold standard for diagnosing rejection remains the endomyocardial biopsy. The timing of rejection is clinically important. Hyperacute rejection develops within minutes to hours, usually due to ABO incompatibility or performed antibodies. Acute rejection typically occurs from days to months after transplantation. Chronic rejection develops over years, leading to progressive graft dysfunction. Infection. Another major complication is infection, which is actually the leading cause of morbidity and mortality following cardiac transplantation. The risk is highest during the first few months when immunosuppression is most intense, and then gradually declines to a lower persistent level. Allograft vasculopathy. An important long-term complication is cardiac allograft vasculopathy. Approximately 50% of transplant recipients develop graft vasculopathy within 10 years. This represents the most common cause of late mortality after heart transplantation and results from diffuse progressive coronary artery disease affecting the transplanted heart. Malignancy. Another long-term concern is malignancy, primarily due to chronic immunosuppression. About 15% of transplant recipients eventually develop cancer. Malignancy is the second most common cause of late death after transplantation. The most frequent cancers are cutaneous skin cancers, followed by non-Hodgkin lymphoma and lung cancer. Medication side effects. Long-term immunosuppressive medications also produce significant adverse effects. Agents such as prednisone, cyclosporin, and tacrolimus can cause important toxicities, particularly nephrotoxicity requiring close monitoring of renal function. Cardiac denervation. An interesting physiological consequence of transplantation is cardiac denervation. The transplanted heart is completely denervated, meaning it loses both parasympathetic vagal innervation and postganglionic sympathetic innervation. As a result, the transplanted heart does not respond to atropine, which normally increases heart rate by blocking vagal tone. Right ventricular dysfunction. Finally, right ventricular dysfunction may occur, particularly in patients who had pre-existing pulmonary hypertension before transplantation. This dysfunction may be accompanied by tricuspid regurgitation and result from ischemic injury, reperfusion injury, or persistent pulmonary vascular resistance. Management includes aggressive reduction of pulmonary vascular resistance using pulmonary vasodilators, and in severe refractory cases, temporary right ventricular assist device RVAD support may be required. To conclude this page, high-risk HFSS cardiogenic shock requiring inotropics or mechanical support and failure of all these surgical options are major indications for cardiac transplantation. Absolute contraindications. Absolute contraindications include active substance abuse, severe pulmonary hypertension, incurable malignancies, irreversible organ dysfunction, and inability to comply with therapy. Successful transplantation requires psychosocial stability and lifelong adherence to medical treatment. Major post-transplant complications include rejection, infection, allograft vasculopathy, malignancy, medication toxicity, cardiac denervation, and right ventricular dysfunction. Now, let's start with ventricular assist device or VADs. Ventricular assisted devices, which are mechanical circulatory support devices designed to assist the failing heart. The primary purpose of a VAD is to unload the failing ventricle while maintaining adequate cardiac output. By reducing the workload of the heart, VADs also decrease myocardial oxygen consumption, allowing the myocardium to recover if the injury is potentially reversible. Depending on which ventricle requires support, VADs are classified as left ventricular assisted device or LVAD for left ventricular failure, right ventricular assist device RVAD for right ventricular failure, bioventricle assist device BIVAD when both ventricles require assistance. A typical VAD system consists of a mechanical pump, an outflow graft, and a drive line that connects the implanted pump to an external controller and a battery pack. These components are illustrated in Figure 48, which compares the HeartMate 3 and HeartMate 2 LVAD systems. Notice the implanted pump, the outflow graft connected to the aorta, the drive line exiting the abdomen, and external battery pack and controller that power the device. Indications for VAD implantation. There are several important clinical indications. Bridge to transplantation, supporting patients until a donor heart becomes available. Bridge to decision, providing temporary support while determining transplant eligibility. Destination therapy, serving as a permanent long-term treatment in patients who are not transplant candidates. Post-operative mechanical circulatory support when patients cannot be weaned from cardiopulmonary bypass despite maximal inotropic support and intra-aortic balloon pump therapy. And cardiogenic shock, where mechanical support can be life-saving. Intra-aortic balloon pump. The page also reviews the intra-aortic balloon pump or IABP. The IABP is inserted through the femoral artery and positioned within the descending thoracic aorta. Its function depends on the counterpulsation. During diastole, the balloon inflates, increasing aortic diastolic pressure and improving coronary artery perfusion. During systole, the balloon deflates, reducing afterload, decreasing myocardial oxygen demand, and improving forward cardiac output. Although less powerful than VADs, the IABP remains an important temporary mechanical support device. Clinical evidence. The highlighted study on the right side compares continuous flow LVADs with pulsatile flow LVADs in patients with advanced heart failure. The key finding is the continuous flow devices significantly improve survival, reduce the stroke and device failure, and enhanced quality of life, establishing them as the modern standard for durable LVAD therapy. Extracorporeal membrane oxygenation, ECMO. The next topic is extracorporeal membrane oxygenation, commonly known as ECMO. ECMO provides temporary cardiac and respiratory support by circulating blood outside the body through an artificial lung before returning it to the patient. The ECMO circuit consists of a centrifugal pump, a membrane oxygenator, venous and arterial cannulas, heat exchanger, oxygen blender, and the pressure monitors. These components are clearly illustrated in Figure 47, ECMO. The figure demonstrates blood drainage through the femoral vein, oxygenation within the membrane oxygenator, pumping of oxygenated blood, and reinfusion through the femoral artery in veno-arterial ECMO. VA ECMO. VA ECMO is primarily used for cardiogenic shock because it can rapidly provide both circulatory and respiratory support. Advantages include wide availability, technical simplicity, rapid bedside deployment. Despite these benefits, overall survival remains approximately 35%, reflecting the severity of illness in these critically ill patients. Indications for ECMO. Major indications include post-cardiotomy shock, cardiac allograft failure, fulminant myocarditis, decompensated heart failure, and refractory cardiogenic shock. ECMO serve as an effective method of extracorporeal life support and can stabilize critically ill patients while awaiting recovery, transplantation, or implantation of a durable ventricular assist device. Cardiac tumors. Incidence. Fortunately, primary cardiac tumors are rare. Most cardiac tumors encountered clinically are actually metastases from cancers elsewhere in the body, rather than primary tumors originating in the heart. Primary cardiac tumors occur in approximately 1 to 30 cases per 100,000 people per year. By contrast, metastatic involvement of the heart is much more common, occurring in approximately 10 to 20% of autopsies of patients who died from cancer. Diagnosis. Several imaging modalities are used to diagnose cardiac tumors. Transthoracic echocardiography, or TTE, is usually the first investigation. Transesophageal echocardiography, TEE, provides superior visualization. Cardiac MRI offers excellent tissue characterization. Cardiac CT defines anatomy and calcification. PET scanning evaluates metabolic activity and detects metastatic disease. When tissue confirmation is required, a transvenous or open biopsy provides the definitive diagnosis. Once a tumor is identified, CT or PET scan assess distant metastasis. Cardiac MRI evaluates resectability and surgical planning. Coronary angiography identifies concomitant coronary artery disease and assesses tumor involvement of the coronary circulation before surgery. To conclude this page, Figure 48 illustrates the structures of modern LVAD system, including HeartMate 3 and HeartMate 2. VADs reduces ventricular workload and improve cardiac output, serving as a bridge to transplant, bridge to destination therapy, or treatment for cardiogenic shock. The IABP improves coronary perfusion by inflating during diastole and reducing afterload by deflating during systole. Figure 47 demonstrates the complete VA ECMO circuit, including venous drainage, oxygenation, pumping, and arterial reinfusion. ECMO is used for severe cardiogenic shock, fulminant myocarditis, post-cardiotomy shock, and decompensated heart failure. Most cardiac tumors are metastatic rather than primary. Diagnosis relies on echocardiography, MRI, CT, PET imaging, and biopsy when necessary, followed by staging and surgical planning. Thank you for attending this lecture. So if you're new to the channel, don't forget to like and subscribe. See you in the next lectures.